femoris, hooks into the top of the kneecap with that hook C-shaped grip along my hand, and I'm just pushing and splaying outwards, stretching that first quadricep open, rectus femoris. Then get into a better position, and I gently duckbill grip, squeeze down the quad while also feeling for sartorius, and then I follow sartorius into the pes anserinus. Now I place my hand up into the ASIS because that's where sartorius is hooking, and it's going kind of slightly out like so where it hooks in. So with my other finger, I'm kind of tractioning down into the sartorius's insertion point and nudging through there. Then I might come back and walk my way up the lateral quad because it's usually really tight on people, all the way up to the greater trochanter. And then I'll switch to like a soft elbow and I'll hit the TFL. Upward pressure kind of like this way into TFL. After those have calmed down, I might use that roller here too. Remember, you can take the patient's leg and do this and roll through their adductors, roll their quad, roll their lateral quad. Really helpful tool to have. Of course, I didn't bring it today again. Squeezing my hands down as I work my way now on the anterior aspect of the lower leg, feeling for peroneus. I do this, I don't know why I've gotten in the habit of it, so if your knees bother you, obviously you have to like maybe use the chair or something. I just kneel on the ground. I just like coming down almost like I'm back in judo class, just doing the kneeling on the ground posture. Working my way up the peroneals, pressing up into the peroneus longus' insertion point, working my way down to brevis, pushing into the bone that way. Tertius if they have it, and then reaching my fingers underneath and kind of opening up the metatarsals. And then at this point I might actually stand back up and tune into their metatarsals. So maybe it's the interossei. Oh, got it. All right, there we go. So let's be very gentle. Was it right in here?
It was lower.
Lower, like down here
Right.
by the toe?
This way, sorry. Yeah, like right there.
Right near.
I might have a bruise though. To be honest.
Yeah, it doesn't feel super tight. It might just be like, yeah, bruised or something. I don't know. Anyway, just kind of opening up the metatarsals, working my way through the foot. Feeling the bottom of the foot. I might even kind of use my thumb and nudge into tibialis posterior, all those different insertion points of that. And then if something does jump out at me in the foot, like let's say I feel a claw toe or something and I work into that, the patient's like, oh yeah, like that toe right there, super gnarly, or like fifth toe right there. Then as I'm working the tendons going up the foot, I might switch and lift their leg, kind of get my fingers behind there and walk my fingers like so to feel the muscle bellies, if it is like, you know, the flexor of the toes or something like that back there. Switching sides. Boink, 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 boink. Here, holding, AIIS, hooking around that patella, switching, squeezing down the quads, really feeling some sartorius on this side, so I'm going to walk down that, check the pes anserinus, pin it in ASIS, just kind of hold, maybe wiggle and nudge a little bit, let that leg just naturally open and relax. Go back, check those adductors on the inside, feeling some VMO stuff, so I'm digging in with my fingers like this and getting really into that VMO. Gnarly in there?
Mm-hmm.
Yeah. Working that, this is where that roller would be really helpful. Lateral quad, palm into it all the way up to greater trochanter, nudging there, and then switching to that TFL. While you're holding pressure up and into the TFL, going up and into the side of the pelvis there, you can also take another hand on the side of like where their VMO and their sartorius is there, and you can externally rotate their leg a little bit to help kind of stretch open that TFL. Then switching, working my way down, and then yeah, I do more footwork on the side. If you want to work on adductors, don't forget you can do this move. If you're feeling a lot of stuff there, you can put their hip or their foot in your hip crease there, and then I do it like this with my palm, or I might even use it with my forearm like so. And you can really do some powerful work through here. Obviously be very gentle because a lot of these insertion points are pretty gnarly. Now working my way up, can I take your hands and have you put them interlaced a little higher in your chest there? Perfect. Now I'm taking my thenar. This is the move I do where I just do it like this. If that's uncomfortable, you could do it like an SI distraction where you kind of reach over like so, and you're pushing down and out, almost like you're opening up the pelvis like a clamshell. So my goal is to first press on the top of the pelvis to get those oblique fiber insertions. I might even duckbill grip into the side of the obliques and feel if there's any fibers, like I felt an oblique fiber going up to the rib here, and then I'm using like a flat edge of my finger to lift up into the rib so it's soft and comfortable for the patient, but also like I can get after some of those obliques going into the under part of the rib cage and those rib insertions. Then after that's calmed down a little bit, then I might take my palm and kind of get in a little bit and then push out. So now I'm pushing into the side of the pelvis almost like I'm opening up. And then after that calms down, I take my thumb, reach in, and I go after iliacus by reaching in with my thumb and then tap, 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 tap along the inside of the pelvis. After that, if you want to do psoas, I don't always do psoas on patients because I like doing my leg stretch move and just kind of giving it a little attention there. But if psoas is a real problem with patients, that's where I use that flat knuckle contact. And I just, either, if the patient can handle it, fine. If not, have them bend their knees, put their feet flat on the table. But it's essentially just pushing in a little bit and just that pressure through the abdomen onto psoas. Let the patient breathe and relax, let them tune into it. Just take your time, don't press really hard. As it starts to release in one area, you can shift to another. Before I do that, usually I do this thumb walk too, and then describe that. And that thumb walk can also be used to work on pectineus, which we talked about too. I can show that again later if anyone wants. Then I do that psoas stretch move. So I grab their leg, bring it off the table, radius on the back of their hamstring, slide down, drop the leg, then I grab with my hand so it doesn't feel like I'm creeping around with my fingertips and it's uncomfortable. Lift up a little bit, but keeping their leg generally, their hip generally neutral and almost a little extended. Hand on top will press and turn and internally rotate. Remember, you can make this like a ninja move where you hook the back of their foot and you can really internally rotate their whole hip like so. To see that from the other side for a better angle. Sometimes I'll just grab their heel down here and just whoop, like that, here. Lift up a little bit just to get some traction. Hand on top, internally rotate, use my foot and balance on one leg to be cool if I want. Boink. And before I did that, I would have done kind of my work on the obliques, squeezing oblique fibers with a duckbill grip, pressing up, flat palm kind of into the side of the rib cage, noticing if there's any spots there, and then down into the ilium, either like so, or even like this with my upper ridge of my finger, I like to use too. Feel free to experiment with whatever hand contacts you want. Next, can I have your arm, please? Take their